Thank you for the opportunity to present the results of the HOT study. This talk will demonstrate for the first time that pre-treating recipients of deceased donor renal transplant with hemarginate can upregulate the protective protein HO1. Despite year-on-year increases in transplant activity, there remains a significant discrepancy between those in need and the transplants being performed. Our renal failure patients have the options of life-saving dialysis, but transplant is preferred because it is cost-effective and reduces morbidity. It also increases longevity. As you can see, transplant doubles the life expectancy compared to dialysis. But as demand exceeds supply, there is now an acceptance of kidneys that previously would have been rejected, including those from older donors or those with comorbidities. And these are more vulnerable to ischemic injury. Ischemia reperfusion injury is the damage that occurs when a tissue has its blood supply temporarily interrupted. This is inevitable in transplantation, as a kidney is retrieved from a donor, put in ice, transported across the UK, and then transplanted into a recipient. Ischemia reperfusion injury has no treatment, but it can be reduced, for example, by decreasing cold ischemic time. But IRI has serious implications. It reduces the immediate function of the graft, as seen by delayed graft function rates, which in this study was defined as the failure to decrease creatinine by more than 10% per day over 3 consecutive days in the first week. And the presence of delayed graft function has a negative impact on longer-term graft survival. There's been much interest in methods to treat or prevent delayed graft function, but few of the potential strategies from preclinical research has been able to transfer into clinical studies. But one area of interest is the idea of preconditioning, and this is when a small toxic stimuli upregulates the body's naturally occurring protective mechanisms in order to protect against a later, larger injury, and the HOT study exploits this. In our study, the protective enzyme of interest was HO1. This naturally occurring enzyme is expressed in many tissues, but for us, a particular interest in renal tissue and also in monocytes and macrophages, the main immune cell in IRI. HO1 is upregulated with many different stimuli, and it protects cells by breaking down the harmful heme compounds that are produced during cell ischemia down into the beneficial anti-inflammatory products, the bilirubin and carbon monoxide. But also, HO1 we know is important in renal transplant because from animal models, we know that it protects against ischemia reperfusion injury, preserving renal function, but this protection is lost when our macrophages are depleted. From human studies, we know that grafts with higher HO1 upregulation, they will perform better. HO1 is upregulated by many processes, including ischemia radiation, but also by this drug, hemarginate. This has been used for over 30 years in the treatment of porphyria, and has been proven in clinical studies to upregulate our protein. It's against this background that the team at the University of Edinburgh, we translated the preclinical research from bench to bedside using the highest quality level of evidence, the randomized control trial. We were approved and funded to recruit 40 transplant recipients when they were admitted to Edinburgh Royal Infirmary. And this is our participant journey. So I contacted all the patients on the waiting list prior to the trial starting to give them the option to decline. I then met them when they were admitted for transplant, and if they met criteria and they consented, they were randomized to either hemarginate or placebo. Our primary outcome was peripheral blood monocyte HO1 upregulation, and therefore blood was taken on arrival. The patient then received their blind infusion, and a pre-implantation renal biopsy was taken. The transplant then proceeds as standard. The blood sample was repeated to look at HO1 difference, and this was done 24 hours post-infusion. We then gave them a second dose on day 2, and they had a renal biopsy requested on day 5. Urine was taken daily, and this looked for us at secondary outcomes. We observed the patients closely for the 7 days of the trial, and then their renal function was followed up for 90 days. And this is our recruitment. The trial started in January 2012 and completed within timescale and to budget. There were 3 recruited patients that were not transplanted, and these were because their kidneys were suboptimal at back table, and the 2 groups had comparable baseline characteristics. And our results show that we achieved our primary outcome. The hemarginate group, in grey, was significantly upregulated HO1, both protein and mRNA, at 24 hours. And also, for the first time in humans, we were able to show that HO1 was upregulated in renal tissue. And this is shown by an increasing brown stain in the hemarginate group compared to placebo. And also, as an original secondary outcome, we looked at hemarginate in renal macrophages. And we were able to show that this too was increased in HO1. The number of macrophages was similar between the groups, but the number of macrophages that expressed HO1 was greater after hemarginate, and it looked like this. In the hemarginate and the placebo pre-implantation renal tissue, cell nuclei are blue and the HO1 protein is red. And the green, this is the macrophage. There was no HO1 upregulation in pre-implantation tissue, but after treatment, the hemarginate group showed significantly more HO1 expressing macrophages, which looked like this. Hemarginate was also safe in our group. There was no adverse reactions, and the adverse events was equivocal between groups. Now, we weren't powered to look at clinical outcomes, but we looked at these out of interest. We saw that the hemarginate group functioned better, with fewer cases of delayed graft function, but it was not statistically significant. There was no evidence in a difference in injury or in longer-term function, but again, these numbers were small. Therefore, in conclusion, I believe that this study offers the first exciting evidence that the important protective protein, hemoxygenase 1, can be upregulated in monocytes, macrophages, and by renal tissue by hemarginate. There is also a trend to improve outcome in a group of our renal failure patients that has very few options. We now plan for a multi-center study which will investigate the impact of hemarginate on delayed graft function rates, and this is planned. I believe that hemarginate offers potential to interact in the damaging IRI process, which otherwise has no cure. Thank you for all these people who helped.